Greetings and welcome, everyone. You made it to the day number 3 of Advances in IBD, and I'm so happy to have you guys here. My name is Dr. Neil Nandi. I'm an IBD specialist at the University of Pennsylvania, and I'm joined by 2 esteemed colleagues to present a talk on iron deficiency anemia. On my right, we have Dr. Millie Long and Dr. Gary Lichtenstein of University of North Carolina and University of Pennsylvania. They need no introduction, and welcome to today's program. Today we're going to be talking about iron deficiency anemia in the context of inflammatory bowel disease. Our talk is entitled Closing Outcome Chasms Through Effective Management of Iron Deficiency Anemia. There are 2 QR codes. You can scan them. The one on the left actually leads you to Enduring Materials and a tool that you can use in your clinics. And the one on the right actually takes you right to the IBD Q&A app. We welcome all questions. So if you have questions, please put them in. I'll be monitoring them here, and we'll try to get to as many questions as possible. This is presented by Creative Educational Concepts and supported through a grant from American Regent. Here are our disclosures and our learning objectives. Today, iron deficiency anemia is not an uncommon topic. It's our bread and butter topic in GI. But in inflammatory bowel disease, it can be very, very critical to proactively manage. So today, we're going to actually talk about proactive screening and testing and management of iron deficiency anemia. But of course, we're going to review the pathophysiology so that we can understand the management algorithm better. And then we're going to review the different strategies and treatments that are available, both oral and intravenous, so that you can proactively manage your patients better. So a couple pre-test questions. You should be seeing these if you're in your Q&A polling area. I'm going to read through them, take your time to answer, and then we're going to get into the talk. In our first question, in order to most appropriately treat those with IDA in inflammatory bowel disease, the subtype of anemia should be defined as to most appropriately guide effective treatment. What would the following lab values likely tell us about the etiology? Hemoglobin 9, T-sats 18%, and the ferritin is 125. Take a look at those answer choices. I won't trouble you with the sound of my voice too much to read them all out. All right, next question. Which of the following statements describes the key distinction between absolute and functional iron deficiency? And all these should be available in your polling questions, okay? Number 3, in a hyperinflammatory condition like IBD, hepcidin levels are often elevated. How and why does hepcidin impact iron supplementation strategies? So what do you think of hepcidin, and how does it impact your choice of iron? Now don't worry, each of these questions, okay, we're actually going to walk through at the very end, so you know the answers. But take a crack at it. Next question. To achieve iron repletion efficiently and conveniently for the patient, it is desirable to strive for repletion or near repletion in 1 to 2 doses of IV iron. Per currently approved product labeling, which of the following IV iron products can be administered in 1 to 2 infusions? We have the usual suspects, some of them, iron sucrose, stearate and carboxymaltose. And then we have a case. We're going to have 2 cases, actually, that we're going to present. One that we're going to walk through, one that we're going to test you on. In this one, it's a 27-year-old female diagnosed with UC about 4 years ago. She's fatigued for the last 2 months, and she wants to see if she can wait with her symptoms to improve because of her busy schedule. Her UC symptoms have flared recently, and her labs demonstrate a ferritin of 28, a hemoglobin of 9.2, and a T-sat of 19%. Given the symptomatic IDA that she is experiencing, her primary care prescribes oral ferrous fumarate, 325 twice a day over the phone. And when she comes to see you about 2 weeks later, she has worsening abdominal pain, nausea, and diarrhea, about 5 bowel movements a daily, with minimal rectal bleeding. She admits she's unable to take the medication twice a day, as she thinks it is causing nausea. Which recommendation is most appropriate? I saw some nods that you've been in this scenario before. All right. Without further ado, I'm going to turn the podium over to Dr. Millie Long, who's going to walk us through the epidemiology, the prevalence, and the pathophys of iron homeostasis.
Hello, everyone. So I'm going to kick us off trying to set the stage and move through some definitions. I think, a key goal out of today is really to have us all better recognize functional iron deficiency in our patients with IBD, because we really can help make them better. So anemia is really the most common extraintestinal manifestation of inflammatory bowel disease. That's a pretty robust number when it's estimated that anywhere from 16 to 74% of patients with inflammatory bowel disease are actually iron deficient. The prevalence is that actually changes by subgroup, very prevalent in children and adolescents, somewhat less so in adults. And really, the majority of this is our hospitalized patients, although we do have iron deficiency anemia in our outpatients as well. Hopefully, we'll be able to catch them when they're outpatients and treat appropriately prior to that profound anemia we can often see during hospitalization. So I want to run through some basic information to make sure we're all on the same page about different definitions. It may have been a while since you've really thought about iron deficiency and transferrin. Iron transport. So transferrin binds to iron in the bloodstream and transports this to cells. And it can bind about 300 micrograms of iron per deciliter. And this is called the total iron binding capacity. And this goes up when the body is deficient. The transferrin saturation is the fraction of iron-binding sites available that have iron bound to them, and this falls as the body becomes iron deficient. So stick with me just for a moment. I teach our medical students in regards to this, and I always like an analogy. And so this mass transit analogy seems to work from an iron perspective. So on the left-hand side, transferrin is the bus that carries the iron, and the percent transferrin saturation is the percentage of the bus on the seats that are full of iron. But when you look to the right, in iron deficiency, the body makes more transferrin. There are more buses going because they really want to pick up every single bit of iron that they can. In iron deficiencies, there's less iron, so there are fewer passengers. So the percent transferrin saturation is really low since there are more of these emptier buses that are trying to hold on to everything. And so from an iron storage standpoint, transferrin and its receptor form complexes on the cell surface, and these get internalized from endocytosis. And iron is really predominantly stored in ferritin, and ferritin levels fall as the body becomes iron deficient. But I think we all know in the setting of inflammation, ferritin can be elevated, so it can make some of these iron studies a little bit more difficult to interpret. There's no regulated excretion of iron. It leaves the body only when cells are lost. Obviously, we see this through blood loss in the GI tract. So sticking with my analogies from a banking analogy standpoint, you've got ferritin, which is your savings account, and you've got hemoglobin, which is your checking account. Initially, when you have GI blood loss, the hemorrhage will cause depletion of the savings account in order to maintain a healthy hemoglobin value in the checking account, so that ferritin comes down. But then unfortunately, ultimately, with ongoing blood loss, the iron stores are depleted, the hemoglobin falls, and that's when we start to bounce checks. So when we think about iron deficiency and inflammatory bowel disease, it's important to think about both absolute and functional, and really be able to recognize functional iron deficiency. So absolute iron deficiency is reduction in iron stores. This can be from blood loss, malnutrition, malabsorption, and you see a low ferritin level. I think we're all pretty confident with that, a ferritin level of less than 30 micrograms per liter. But there's also functional iron deficiency, and this is disturbed iron metabolism in the bone marrow and systemic iron utilization. So the iron stores themselves can be normal or even elevated. And this can be caused by chronic inflammation, the hepsidin that you saw in one of our pre-questions, and kidney dysfunction. And so in this setting of functional iron deficiency, the serum ferritin may actually be normal or even up a little bit, and you really want to look at the TSAT. And a TSAT less than 20 is synonymous with functional iron deficiency. And I really, in my practice, I really do start to treat with this, and it really seems to help my patients. And so inflammation in IBD really reduces this oral iron, the iron availability. And so this hepsidin that becomes important, you can see blocks intestinal absorption, but it also blocks export from macrophages and hepatocytes, and it results in this iron deficiency anemia. So how do we define anemia? Just keep in mind that it's defined differently for women in the pregnant and non-pregnant state, and also for men. These are some of the WHO criteria, recognizing that men are about a point higher in the healthy norm. So when we want to evaluate iron deficiency, there are a series of labs we get, right? So we get a CBC. The first sign is elevation in the RDW, followed by a falling MCV. And hemoglobin and hematocrit fall last. So just recognize that it's an order. Ferritin levels are measures of iron stores, but can also be elevated with inflammation. And so really, if it's less than 30, we know iron deficiency is present. But in a patient with a chronic inflammatory condition, remember, you're going to want to have a higher threshold, such as a ferritin less than 100, or even a little bit higher than that with that TSAT being low. So really, it's important when you're getting iron studies to get the whole panel. So I get the serum iron, the ferritin, the TIBC, and the TSAT. Again, remember, the serum iron falls, the TIBC increases, and that transferrin saturation falls. And the reason this becomes important, and it seems like a simple concept, but in fact, this is often misinterpreted, including by primary care physicians. So this isn't something we can necessarily leave to the primary care physicians. This was a study that looked at interpretation of iron studies. And in fact, they were really pretty incorrect, particularly in certain scenarios. This most often happened with a low TSAT and normal to low ferritin. And of this, during this study, only about half recommended bidirectional endoscopy for adults over 65 who actually had iron deficiency. So misinterpretation is common, and obviously underuse of bidirectional endoscopy can lead to delayed consequences. And so in the figure on the right, the blue is the correct diagnosis, but all the way to the right, you'll see there was a very high percentage, almost 30%, of incorrect diagnosis when the definition we use of the low TSAT and the normal to low ferritin level. So again, this is something we can recognize and potentially improve for our patients. We also need to differentiate between iron deficiency anemia and anemia of chronic disease. Certainly that's something we see fairly commonly. Many of our patients have other comorbidities as well. And obviously with the iron deficiency anemia, again, we're looking for that decreased transferrin saturation, the decreased ferritin. Transferrin can be increased and the CRP can be normal. Anemia of chronic disease, you might see more of that CRP being up, and you can see a variety of different components. So how do we treat? That's what we're here to talk about today, and actually following my presentations, Gary's going to walk us through all the mechanisms we have available at our fingertips, and we do have more choices, which is outstanding. We certainly, first and foremost, need to treat the underlying cause. Neil pointed that out in the case that he presented at the beginning. We're going to talk about that case at the end. We need not only to treat her iron deficiency, but obviously to treat her IBD. An oral iron replacement, we all know this from insurance companies, it's considered the first-line treatment of choice, but really recognize that there's limited efficacy in the presence of chronic inflammatory processes and very limited tolerability in IBD. So I typically document that I've advised my patients on a trial of oral iron, but we really do see pretty common side effects, nausea, constipation, and we also know that it's likely not going to be as effective in our patient population. And so if this is intolerable or ineffective, IV iron is indicated. Certainly there are rare risks of anaphylaxis. We'll talk about this, the individual risks and benefits of different therapies. And certainly IBD and potentially gastric bypass also, just because of a malabsorption component, are indications. And there was a nice recent Cochrane database systematic review that I put as a reference in the bottom that I'd like to point your attention to, which showed that IV iron likely leads to greater response than oral iron in IBD. So it's a great reference if you do need to argue with insurance companies. The number needed to treat is only 11. So this is something that we really do need to start operationalizing in our practices. Certainly patients can get blood transfusions if necessary for correction of the anemia. We obviously do that more often in the hospital associated with severe anemia. So I'd already mentioned that the prevalence is high. When you think about the incidence of anemia, it's actually 93 per 1,000 person years, which is nearly twice that of a non-IBD group. And IBD patients spend nearly 53 days a year with anemia. Think about that, 53 days. So that obviously impacts their quality of life. And there was a large national VA population study that showed that only 37% and about 3% of anemic IBD patients received either oral or IV iron therapy during that follow-up. So obviously we have some room for improvement. When we think about anemia by IBD type, the take-home message from this slide is we probably see more in Crohn's. So the Crohn's is highlighted in the purple and the green. And the other take-home point is that we see anemia really early in diagnosis and less so as they move along. Hopefully that's because we're better controlling the underlying inflammation and the underlying disease processes. But this is something we really need to emphasize, particularly early on. And in this study, elevated CRP independently was associated with anemia. So there's clearly a component of active disease. When we think about patient outcomes, these are important. These are what our patients come to us. I think that all of us recognize that many of our patients come to us fatigued. And sometimes we can help, sometimes we really have to dig into it deeper, but this is one very common avenue to help them with their fatigue. When patients with anemia have a lower overall health-related quality of life, They have IBD-specific quality of life that's lower, and of course, increased fatigue scales. But importantly, and something that insurance companies should care about, is that they also have increased healthcare utilizations, significantly more hospitalizations, if they do get hospitalized, higher length of stay, increased urgent type care visits, and higher cost. And so, therefore, this is something that by addressing earlier in disease course, we may be able to help to improve some of these outcomes. And anemia is also associated with significant postoperative outcomes as well. This study on the left, you can see the healthcare utilization that we already discussed, but on the right, even in patients who've had surgery with inflammatory bowel disease, any outcome you look at, you can see that anemia is associated with the worst outcomes. So reoperation, postoperative sepsis, increased length of stay, even mortality. So this is something that obviously we have some room to help to address. So in summary, because I know it's actually most important that we get to talking a little bit about these iron and into our case, I'd just like to emphasize a few points. So when you diagnose iron deficiency, please look at both the serum ferritin and the TSAT. And I've found in my practice that at this point, the majority of my patients whom I'm catching with iron deficiency, it's actually that TSAT. Misinterpretation of iron studies is common. And you can hopefully remember the bus and the bank analogies that are going to help you to think about the different rationale behind the tests and how iron can be malabsorbed and how we can appropriately replace it. Consider both absorption and loss in the IBD population. And remember that prevalence is high, Crohn's more common and earlier in disease course, but that treatment rates are low. So this is something we can modify. IV iron modality is often preferred versus oral, and we now have a great new systematic review to help to reinforce this, that it's more effective in patients specifically with inflammatory bowel disease. Because this so dramatically affects quality of life and healthcare utilization and cost, we can really make a difference in this area. And so with that, I'm going to turn it over to Gary, who's going to talk through some really exciting data on currently available and next generation IV iron products for our IBD patients. We're going to try not to fall off the back of this.
Yeah.
If you hear a clunk, it was a mistake. So thank you. Millie set me up nicely to really review what do you do in clinical practice. What I'm going to do is try to focus on the evidence we have, somewhat of an algorithm. I'm going to leave that more to Neil to talk about the algorithm. You'll see several directly. So you may say oral iron. What's the advantage? Well, we know it's absent inflammation, it works pretty well. It's been around for years. But the issue is it's got some good things and some bad things, the good and the bad side. It's low cost, very low risk of severe adverse events. So we're going to talk about severe adverse events based on controlled data. It's not so low as you think. There's no strong evidence that one formulation is better than another. You've heard of the vitamin C addition, things of the nature. But there's no comparative effectiveness data for oral iron that's truly been put to the test with the appropriate number of patients. The big issue is GI intolerance, nausea, flatulence, diarrhea, low adherence rates, 10 to 32% in some of the trials. And you're going to see that directly when looked at in comparative. The significance of ingested iron is unabsorbed. So you truly only need to take iron once a day or every other day, may even be better based on some very recent data. Concomitant medications can limit absorption. So we use these commonly, other medications, things that block the pH, a PPI, quinolones, phytates, tannates. And the other thing is there may be inadequate for ongoing severe blood loss. So patients that have severe anemia, that's not appropriate. IV iron, on the other hand, is useful for severe anemia. And for patients who don't tolerate oral iron, it's more effective in the setting when you have inability to tolerate oral iron. It's more rapidly available to correct the iron deficit, if you would. And you can give higher doses. You can give 1,000 milligrams in a single dose based on data from 2 agents we'll talk about. Minimal GI intolerance. The disadvantages are it's costly, it mandates an IV infusion, but it may require repeat infusions with certain formulations, and we'll talk about that directly. And hypophosphatemia has recently come to play, and that's something we now know the mechanism by which that occurs. So here's a classic study. Kolnik studied this. Looked at the rapidity of treatment effect a hemoglobin increase by 2 grams over 2 weeks. And you can see IV iron, the parenteral formulation of ferric carboxymaltose, was more beneficial than oral iron. It was more rapid and more robust, the benefit. And there's other studies as well that have shown this. Looking at 9 different randomized open-label multi-center clinical trials, here's the data, oral versus parenteral iron. You can see the blue versus the black. The black is parenteral iron, the blue is the oral. Nausea, constipation, diarrhea, headaches, and a host of other different adverse events come about when using this in patient populations. Hence the next generation. And this is what we're going to talk about, some of these agents directly. Schematically, you can see the diagram on the right. There's a carbohydrate shell, and there's a central iron. And this is all these are directly, whether it's gluconate, sucrase, carboxymaltose, or other formulations. It's a particle size, a low molecular weight greater than a high molecular weight directly. And looking at the data in the past, people have a jaded view. Iron Dextran was given years ago, and 3% had severe reactions, life-threatening anaphylaxis in 0.6%, and hence they said, I don't want to use this medication. I'd rather give oral iron and see what happens. But the reality is the newer generation data is such that it's very uncommon, 0.1, 0.2, 0.3% in some of the newest agents that we have directly. So we're now very accustomed to giving biologics, hence we recognize these adverse events can easily be managed, and we'll talk about that directly. The timeline for formulation, it really wasn't until 1991 when low molecular weight iron came about in the form of Dextran. And subsequently others came about as well, as is highlighted here. The most recent one was 2020, ferric derisomaltose. So what do we have available? So we have 6 different formulations in IV available to us directly. Iron Dextran, you need a test dose prior to giving that, given the rate of anaphylaxis is higher, and that's based on label. Ferumoxytol is useful as well. 510 milligrams single dose can be given subsequently 3 to 8 days later, and then ferric gluconate as well. But these formulations are the lower dose formulations which can be administered, 125 milligrams in an hour for the gluconate. If we look at the other formulations, sucrose is also low dose, 100 to 400 milligrams per dose, so you may need to give 5 different infusions over time if it's 200 milligrams, which is a common dose. Ferric carboxymaltose, 750 or 1,000 in a single dose. So that's a high dose formulation, and safety looks quite good, and we'll talk about that. And ferric derisomaltose as well, 1,000 milligrams in a single dose. So you have high dose administration as a potential when using these 2 agents directly. There's some randomized controlled trials that are done, not yet published. And I'm going to put these in, and you have these handouts. If you look, you can download all the slides from today's presentation. And I'm just going to put these up if you want to review phase 3, 4 trials not yet reported. We also have ongoing trials, comparative effectiveness trials that are ongoing. We don't have the data for these yet, but these are just for your edification if you have a chance to go and read these if you so desire. Pediatrics. In a pediatric population, the use of agents as well was looked at. Pediatric population over the last 4 years, ferric carboxymaltose data. This was looking at 1,000 milligrams overall. No severe infusion reactions and only about 10% required pre-medication. So these are pretty impressive data and helpful for us to consider these to safely use these. And here's the data you can see, pre-ferric carboxymaltose post, and these are prospective trials in pediatric IBD patients found that about 2/3 got this formulation, had a resolution of the iron deficiency anemia, and 81% had resolution of iron deficiency. So very, very helpful to give this rapidly to a sick patient who needs a rapid fix. Adverse events. So if we look at these directly, this is a study retrospective 2010 to 2014, U.S. market claims data. Overall, hypotension, anaphylactic shock, and bronchospasm from 6,100 patients is relatively uncommon. And if we look at the particular agents in the bottom right, you can see ferric carboxymaltose had none, ferric gluconate, furomoxetol, iron dextran, and iron sucrose all are relatively low directly. So 1.3 adverse events for 100 IBD patients directly, and the event rate is per 1,000 IV infusions. A systematic review subsequently and a network meta-analysis looking at the efficacy of IV formulations, looking at this compared to oral iron. 5 randomized controlled trials over 1,000 patients. Ferric carboxymaltose, iron sucrose, and iron isomaltoside, in other words, derisomaltose is the other name for this, were looked at directly. The dextran, the furomoxetol, or sodium ferrigluconate were not looked at, and the most effective was ferric carboxymaltose, and more effective than oral iron. If we look at management of adverse events, what are the things you think of? Anaphylaxis, you can treat with steroids, antihistamines prior to or subsequent to if this occurs. Hypotension may resolve spontaneously or stop the infusion and then resume the infusion subsequently. And extravasation, choose a large vein, put this in and watch carefully for pain, discomfort at the site. These are the major adverse events that we see. It's similar to biologic infusions, that we have very similar adverse event profiles, and we manage these very similarly. There's next generation products, and I mentioned something, hypophosphatemia. Well, this has recently been recognized to occur, but if you look at the numbers, it's relatively low, but it's something that has to be looked for. 0.4% with furomoxetol, ferric carboxymaltose 2.1%, and hypophosphatemia in ferric derisomaltose was 3.5%. And this is interesting. It's actually a mechanism of action from fibroblasts. FGF23 is elevated in patients when they have iron deficiency or when they have difficulty with regards to renal failure. And same as IBD, it's generated in the bone, and this leads to hypophosphatemia. So we now know the mechanism, and I can foresee future studies measuring this directly as a predictor. Not yet done, but this is just reported in January of this year in JAMA. So to summarize, IV iron is appropriate as a first-line therapy in many patients that have GI diseases, but the most interesting one to me and to the three of us here is IBD. That's what we're talking about today. It's more rapid, complete repletion of iron stores. You can avoid the GI side effects, particularly in patients that are known to have them in the past or who have IV iron required that have significant inflammation, and IV iron is not going to be taken up. This is where the oral iron is not taken up. This is where parenteral iron is very useful. 3 formulations for general treatment, iron dextran, ferric carboxymaltose, and ferric derisomaltose. For kidney disease, the other 3 are approved. Adverse events can be managed. In a patient you see in the office, they have inactive IBD, and they have anemia. What do? Well, we normally do an endoscopy and a colonoscopy. You want a biopsy for H. pylori, check for celiac sprue, and then capsule endoscopy is sort of the next phase. These are based on the AGA guidelines recently published for iron deficiency. So the clinical scenario is important. We use a treat-to-target approach for IV iron as well. You have inadequate iron stores, you identify the problem, you then treat, and then go ahead and verify that you've had a benefit or a lack thereof and modify the appropriate course based on that. An algorithm. I present this here for you to peruse at your leisure, but Dr. Nandi is going to go over a management algorithm in the future. This really incorporates many of the things that Millie and I discussed that you can look at for clinical practice. So to really put it all together, iron deficiency anemia is the most common source of anemia in patients with IBD, and it's very, very prevalent and often under-recognized, as Millie alluded to. Early recognition is important because we recognize that downstream benefits can be quality of life, and certainly hospitalization is one of those endpoints we try to avoid. Treatment decisions should be based on objective measures, and they're appropriate. So document it's present. All anemia is not iron deficiency, and it can be a functional anemia or a true iron deficiency anemia, and differentiate those directly. Oral iron should be tried when appropriate, and this is something very appropriate to use when someone has mild anemia, inactive disease. That's the perfect scenario. And Millie showed us the different gradations of anemia based on the WHO, mild, moderate, and severe, and these are different. When severe anemia is there, think of parenteral iron. IV iron is to overcome the inflammation-mediated lack of uptake of iron through the enterocyte. Remember, the duodenum and the jejunum, proximal jejunum, is where iron is taken up, and it's not going to get taken up when you have active inflammation, and the hepsidin is an important component of that that we'll emphasize in the near future. And those that cannot tolerate oral iron should get parenteral and use the treat-to-target approach, not only for the biologics we use in clinical practice, but also for iron therapy. Identify the issue, make sure that it's iron deficient. If it is, treat that accordingly based on the scenario. If oral iron is appropriate, give oral iron. If not, then use parenteral iron, but recognize the frequency. Remember, 2 formulations, you can give 1,000 milligrams, others you have to give more frequently, and sometimes this is driven based upon the insurance company's desire, which one they've made a deal with and which one that you can use. But for patient satisfaction and ease, try to give less often infusions if you can, because that's an important thing that we look at. The less time a patient has to miss to come in to get an infusion or an injection, the better it is for their outcome directly. So with that, I'll stop and I'll turn the microphone back to Neil. Thank you.
Thank you, Gary. All right. So now, in these next few questions, we're going to actually go through those pre-test questions, address a case as well, and walk through an actual patient. And I like this aspect because I want us to play make-believe and pretend we have a live human being in our clinic as we walk through the patient. So this is a 29-year-old female with a history of bloody diarrhea, nonspecific abdominal bloating, discomfort throughout her college and her 20s deemed IBS. Here at an IBD conference, we hear this all the time, right? Later, postpartum, she developed initial mucousy diarrhea 3 to 4 times daily associated with left lower quadrant abdominal pain. She has a past medical history of some reflux, menorrhagia, no known family history of IBD. She happens to smoke a pack a day of cigarettes for 9 years. She does happen to take ibuprofen only on occasion as needed during her menstrual period. And we get some labs, right? Get a basic workup, and we see that she has a normocytic anemia. Ferritin 17, her chemistries are normal. Her albumin is preserved at 4.2. Her CRP is normal, 2. Her vitamin B12 is pretty healthy. Her vitamin D level is low. Even here in the great state of Florida, vitamin D deficiency can be rampant. Her stool studies are negative for C. diff and other enteric pathogens, and her calprotectin, notably, is elevated at 406. All right, so we've got a young lady with change in bowels, elevated calprotectin, and a normocytic anemia. We do a colonoscopy, right? And we intubate the TI, we see that it's healthy and normal, and we observe that she has confluent circumferential inflammation all the way from the anus to the transverse colon, 1 to 2 millimeter aphthous ulcers, no friability, some mild loss of vasculature, and some haustral edema. We call this a Mayo 1. Her biopsies are consistent with the diagnosis of mild pan-ulcer colitis because it's beyond the splenic flexure. What medical therapies for UC are appropriate to use, and how should we approach her anemia? So in this case, this is an appropriate patient for mild to moderate UC to give her a mesalamine challenge. And we want to avoid systemic prednisone and the side effects of steroids, so we give her budesonide MMX, which is an extended-release formula that melts throughout the entire colon, while we bridge her on a trial of mesalamine. For the 8 weeks, she has symptom relief, she feels a lot better, and then we begin her on oral iron.
And Neil, before you move on, I think that I totally agree with your management, but I also think in these mild settings, it is okay to try to induce with mesalamine as well. Obviously she was symptomatic, but she wasn't terribly symptomatic, so you could consider a trial of the oral mesalamine. And I often do add in the topical enema as well. That's a different form of combination therapy. But if they're having any urgency, lower abdominal symptoms, the enemas can be really helpful and additive. And in fact, guideline recommendations do recommend both if the patient will tolerate it. So I just wanted to point out it's not wrong to do the budesonide MMX, but there are a segment of patients that actually respond to induction to mesalamine.
And to your point, there's some really good data to show that they have benefit to oral and per-rectum mesalamine together rather than either or. Gary, would you do anything different in this too?
I agree with Millie. I mean, I would probably err on the side of using mesalamine, topical and oral. The median time to response, if you look at most of the trials, is about 10 days to 2 weeks. And if you look at the topical therapy with mesalamine, it's 3 to 21 days. So it's going to be relatively rapid. If patients start to do worse, then you have to bail out and you say, then consider a steroid. I think the key is have the patient communicate with you, very close follow-up, and it's obviously a shared decision with the patient. Most patients would prefer not to take a steroid.
And I would say the other thing that I would be talking to her about before starting the oral iron is I think both Gary and I emphasized that there can be some GI intolerance, definitively. And I warn patients about this up front, particularly this young lady who had been told she had IBS for years and she had some bloating, she's had some nausea, I think. She had some of the symptoms that we see with oral iron. Because what I don't want is me to start her in this and her say, this makes me feel worse, and not take it and not tell me, right? I need to be able to understand, is she tolerating the oral iron? I warn her what those symptoms are. And sometimes even within a few days, they call back and they say, I cannot tolerate this, even once a day. It really is worsening my symptoms. But then you can document intolerance of oral iron, and then that allows you to move on. At least in my practice, I've found that the IV iron really does not have GI intolerance, and it can be better from that perspective for these patients. I don't know if Gary feels differently.
I agree. And one thing to point out is, here it's once daily oral iron. Anything more than that is not necessary.
Oh, yeah, don't even try.
Even there's now data to show that twice daily lessens your response rate. So every other day, there's some now very recent data that's been published this past year to suggest may be effective. And giving something such as a colase or a stool softener concurrently in those that are known to have problems is certainly something to do. And we're not saying don't use oral iron, but only in the right circumstance should it be considered.
And I think that in my practice, I've just found that adherence to this is pretty poor, and I just need to know about it if they can't tolerate it and they aren't adhering. For some, they tolerate it wonderfully, and that's great. And we monitor to make sure they're responding appropriately. But this is one thing that patients aren't necessarily going to tell you that they stopped.
And if you've ever wondered why oral iron gives any gastrointestinal side effect, it's called the Ferritin reaction. It's a chemical reaction if you go back to organic chemistry. It binds with reactive oxygen species in the gut, and that is very inflammatory. So like Gary said, you're going to choose oral iron in the patient carefully that you're going to challenge, but somebody who has active disease is discouraged because you might increase some of their symptoms that may masquerade as flare. Since we talked about different ways to treat this patient, it's always good to have proactive conversation of, well, if we do this treatment in terms of medical IBD therapy and it doesn't help you, what's the next step? And Gary started to talk about that, but would there be anything, would you counsel the patient at this stage of the game, and what would you prepare, what would be your threshold for graduating therapy?
Right. So at this point, particularly at Mayo 1, maybe some of that description could have been a Mayo 2. There's not really such thing as a Mayo 1.5, but maybe this is what this lady is. They respond really well to mesalamine. So I kind of introduced this idea. I talked to them about what the importance of the enemas to help to augment the response. And then I used the budesonide MMX or a steroid course if needed as this is what we'll go to next. We have a plan. We have a monitoring plan, should your symptoms not improve or exacerbate. I think that I mentioned to them that there are other classes of medications that we can use and that we'll you can introduce the idea, but at this disease severity, I'm not necessarily already getting my Hep B surface antigen, my TB testing, and kind of prepping the patient for advanced therapy. That would be next if they required a corticosteroid taper. Often many patients do incredibly well. We don't see a lot of these patients at the academic medical centers, but many patients with ulcerative colitis do very well with mesalamine.
Very good. So to summarize again, we have a 29-year-old female, postpartum, smoker. She happens to have ulcerative pancolitis. Mayo 1 to 2. She started on a course of mesalamine and this budesonide and oral iron. And let's just talk about some other causes of anemia, right? Common things being common, we have to think about the other things that can contribute to this. So in just terms of iron deficiency, we have to account for menstrual losses, which are very common, and she told us that she does have a history of that. She was taking NSAIDs at one point too, which could be causing some inflammation as well. Malnutrition, if you're not feeling well, right, you're having a flare, you're not having as much intake, although that has to be going on for some time. But then there's other things that can really cause anemia that can overlap with iron deficiency anemia depending on nutritional state or the type of disease you have, such as in Crohn's with vitamin B12 deficiency or folate deficiency. It's incredibly difficult in America to become folate deficient because most of our food is so devoid of nutrition that manufacturers actually add nutrition back, and because we're so sensitive about avoiding the consequences of folate deficiency, it's already folate fortified, actually. I think Susie Kane actually did a study at Mayo, and she showed that checking a folate level 9 times out of 10 was not cost ineffective. And then, of course, there are other rare causes, such as myelodysplastic syndromes, aplasia, or other hemoglobinopathies, at which point you've gone on much in the workup, you're employing the aid and assistance of a hematologist. So she comes back 2 weeks later, and perhaps not surprisingly, thanks to the discussion we just had, she's got some worsening abdominal discomfort. No fevers, thank goodness. She did stop the NSAIDs. She listened. She stopped smoking. But she says she's maintained. That
might have hurt her.
And I was going to ask you, what do you guys think about that?
I mean, we obviously recommend smoking cessation, but just recognize that we don't know exactly why, but smoking can be protective from an ulcerative colitis standpoint. So when I do finally convince patients to quit, sometimes they can have an exacerbation afterwards. Still the best thing they can do.
Absolutely.
It's the lung cancer, the CVA, the MI, the host of other things that will confound you if you have problems. I think the other thing, Neil, is the vitamin D level. There's 4 controlled trials at least that have looked at vitamin D supplementation in mild to moderate ulcerative colitis that have shown benefit over placebo. So that's something we would treat up front, and relatively high doses, 50,000 units 3 times weekly, and then maintain on 2,000 or more after 3 months as a routine. And a level of 30 or above is sort of the target you want to be at based on the Institute of Medicine suggestions.
Yeah, and vitamin D supplementation in a variety of illnesses has panned out in some and not in others. For instance, for cerebrovascular disease, cardiovascular disease has not panned out. In IBD, there was those 4 trials that actually Dr. Lichtenstein just quoted. We think that vitamin D is obviously important not just for the immune system and the bone health, but many, many things. So I think the benefit far outweighs the risk, and something you need to actually think about. So this young lady, the doctor has decided to do another flex sig, and they see slightly more increased disease. What are you thinking at this point if she's saying she's having more flaring symptoms? You tell her to stop the oral iron. What else would you do in this case?
Well, in this case, she's actually already on budesonide MMX, so she's already on a corticosteroid. Now, granted, it's not as potent as prednisone. I think that budesonide MMX works pretty well for mild to moderate UC. I don't find it working well for moderate to severe, and you'll note that we actually specified that in the most recent ACG UC guidelines. So, in this situation, I do think we've confirmed that there's active inflammation. I mean, a more realistic approach would have been she comes back in with symptoms and you do a fecal calprotectin. Again, you had that baseline, so you could kind of see, has there been improvement? This obviously would be increased. And so at this point, I would actually give her a course of corticosteroids. And whenever I'm using full-dose prednisone, I am having the conversation about that next stage of options from a medical therapy for more of a moderate ulcerative colitis. I also think, Neil, I'd stop her oral iron. It's probably not helping her belly pain.
No.
Gary, anything different?
I agree. I think this is a very rapidly progressive disease. 2 weeks, you're looking at a person who's progressed from more the lower end of disease to this. And the question is going to be, is this going to lead to a colectomy? And I think you need to intervene, and you need to do something that changes the natural course of disease. So, biologic, small molecule, you have to be thinking that and getting them prepped. The other thing is round up the usual suspects, C. diff, enteric pathogens. Make sure you're not missing something, because those are things that commonly come about in patients when are thought to have flares. Look for celiac sprue as well. Sometimes that's something that can confound symptoms. It won't give you the ulcerations in the colon, but it clearly can make things somewhat worse.
Very good. All right, so we look at her repeat labs, and just in these few weeks, we see a change, right? We see that she has the beginnings of a microcytic anemia. We see that her saturation is down. Her CRP is further elevated, and her calprotectin has continued to trend up. So she's not getting better, she's getting a little sicker. And we talked about what we would do, some of the options that we might consider. Let's stop for a second here and think about what's going on in her body. So my colleagues already repeated some of these pearls twice. I think you learn things best when we repeat it 3 times. And so hepcidin is incredibly important. On the right side, the right diagram, when we're in a iron deficient state, but there's no inflammation, we're able to actually absorb iron. We do that through the enterocytes. The duodenal enterocyte membrane has a receptor called ferroportin. Get it? Ferroportin. We're able to absorb iron from the gut, from nutrition, and we're also able to release iron from stored sites, such as macrophages and hepatocytes, due to the same receptor, ferroportin. But when we have systemic inflammation, doesn't have to be in the gut. Many other disorders can actually qualify for systemic inflammation. We can see hepcidin rise. And when hepcidin rises, it inhibits and downregulates ferroportin. So now you can hold iron and dietary iron to the gut, and it will not be absorbed. You cannot release your iron stores. You can have normal iron stores, but they won't be released. So your functional pool of iron being transported throughout the body, there's no iron to actually transport and make new globin. So in systemic inflammation, we have elevated hepcidin, which leads to a functional iron deficiency. So why IV iron in active IBD? Well, we just illustrated through this case and through our discussion that active disease can actually impair iron absorption, right, because of the elevated hepcidin and downregulation of ferroportin. There could be GI intolerance, and when you go on oral iron, many patients are not adherent to oral iron. It's hard to take something more than once a day, especially if it's causing any type of GI intolerance. And then, of course, the significant anemia itself might require, the clinical situation itself might demand something more effective, that being intravenous iron. Now, IBD Chorus, which is a quality initiative through the Crohn's and Colitis Foundation, they have a pathway, an anemia pathway in IBD. And it's fairly simple. You're looking to once you establish the diagnosis of iron deficiency or iron deficiency anemia, both are recognizable. You can be iron deficient without anemia. You also want to look at the disease activity. If you have inactive IBD, that's the patient that you want to use your good clinical sense of whether they can tolerate oral iron. Now, personally, I would only do this, I honestly don't do this much, because most of the patients I see have pretty significant iron deficiency, but in very, very, very mild inactive iron, mild anemia, I might choose oral iron, but most of the patients I'm seeing are further along, and I'm thinking of IV, which we'll discuss. Would there be any other types of patients you guys would do oral iron in, an IBD patient with inactive disease, or do you guys go right to IV?
I do. I give oral a try. And I think even in active IBD, it's not unreasonable. It's just you have to monitor. I think this is the theme of the meeting. You have to monitor. You can't just set it and forget it. Like, you have to really reassess. Are they responding? Are they tolerating it? Are they adherent? Have their stores increased? And if they haven't, then you pivot pretty quickly to IV iron. I also, frankly, like having intolerance or inappropriate response to oral iron being listed in their problem list after that, because then obviously I can continue to use IV iron moving forward. Many insurance companies require that for use of IV iron.
That is a good documentation to save yourself some hassle there. Gary, anything else to add to that?
I do the same. I think it's important that you recognize which patients do and don't respond and put it as a problem issue, because then if a patient then comes back and says, I didn't tolerate it, and then it would be under the, quote, allergies, but mention specifically what it is it didn't tolerate. And the same as parenteral iron, if you don't tolerate one formulation, it doesn't mean you don't tolerate
Correct.
the other. So IV iron, quote, allergy is due to the carbohydrate, the outside core, not the core itself of the iron, and you may tolerate others. So that's commonly a misconception that people have.
Mm-hmm. And so we're going to think about intravenous iron in these patients. Now, Gary showed a slide doing a head-to-head in an IBD population of one of our IV iron formulations against oral iron, ferric carboxymaltose against oral. And you saw steadily that the ferric carboxymaltose group, the hemoglobin, steadily increased. If you actually look at that same study and you look at the iron indices, the oral iron group actually became more iron deficient And that makes sense, right? Because you have systemic inflammation, they're not absorbing the iron, you're not treating the underlying disease yet, and so they continue to become oral iron deficient. So IV iron, in my mind, for the right patient, is a proactive approach. We're actually going to bypass the enteral absorption. You're actually going to get the iron into the circulation so that you can actually impact the anemia. So in an active IBD patient, especially one who's more moderate to severe, very intolerant of oral iron, that's the patient you're going to use an IV iron. And you can choose to consider a hematology referral. Often in our clinic, we just take control because we don't want the patient to have to go see yet another doctor, another appointment, another parking fee. It's so easy because it's going to be infused in the same unit or home infusion site even that they're going to be at. So we want to actually be proactive about this, right? So we've elicited that they have anemia, we've screened and looked at their indices, we've recognized their disease activity, and now we're going to actually give them iron. But the key here is this, proactiveness, right? We're going to recheck in 4 weeks what their actual level is. So imagine that, right? Iron is so amazing, that the body's so amazing, that in 4 weeks it can actually take that iron and actually give you, new red blood cells and new hemoglobin. So you don't have to wait 6 weeks, 8 weeks, or 3 months. You can check in 4 weeks. And if you still haven't made the impact, infuse or treat again and recheck until you've accomplished your goal, treat to target.
Neil, I just wanted to add one thing. That pathway was for anemia, but we actually had a question, do you actually treat like this if someone is iron deficient without yet being anemic? And the answer to that is yes. If you think about that bus and bank analogy, this is just a matter of time until they become anemic. And so I look at it as being proactive. When they're at the state of iron deficiency, I will replete them then. Gary, do you do the same?
I agree fully. And one of the things to bring out is you may think of a patient recently that you've admitted to the hospital and got a transfusion. All patients that get transfusions need oral or IV iron. And that's something real important because the iron content of transfusions is very low. Mm-hmm. So that's something that regenerates the ability to create future red blood cells. So think of that whenever a transfusion is given, whether it be a GI bleed, a patient who's obese and who had a gastric bypass came in and needed a transfusion. These are all things you want your iron stores to build up.
That's actually a great scenario there where you have the patient who's been hospitalized, right, and they've gotten some blood transfusion. Most hospitals carry iron sucrose, but they may not have been fully iron repleted. So 2 questions come up. 1, how do you calculate the iron deficiency? And then 2, how do we make sure that they actually get repleted outpatient? And that's usually a place where the patients get lost. The answer to the first question, which was asked by one of our attendees, was how do you calculate? There's something called the Ganzoni's equation, Ganzoni, Ganzoni. You can search for it on Google, and it basically looks for gender, target hemoglobin, current hemoglobin, and weight, and it can give you an estimate of iron deficiency. Across many, many different indications for iron deficiency, be it dysmenorrhea or celiac or IBD, the average in most studies has been 1 to 1.5 grams deficit. So most patients, by the time they get to anemia, usually are pretty deficient, but of course it depends on their clinical context. And then 2, I would ask, this is the patient, as a primary care, as a gastroenterologist, you're seeing them on post-hospital discharge. This is one of those things that even though they might have gotten a little repletion inpatient, you want to make sure that you can follow up this as an outpatient. So you might start with repeat indices.
And I just usually give the iron. I know Millie and I were having a sidebar.
Mm-hmm.
We don't use that because it's not as accurate as it should be. It's easier just to give the iron, and the excess, don't worry about it.
A gram is pretty much what you're going to give. Whether it's these day and age, we often have to give iron Dextran first, and then if they don't tolerate it, obviously we can move to another agent. However, over the past year, I don't know if others have had this, but there was a huge iron Dextran shortage, so we were really having to give many other formulations, but it's usually about a gram, no matter what the formulation is.
Yeah. So you can use that tool. It's an estimate, but use your best judgment. But the point is, you don't know you've given enough until you recheck the indices, and then you'll know how much more to give. So she comes back another 2 weeks later, and the team said, we have to start some type of advanced therapy. So they start combination therapy, infliximab and azathioprine, which is in conjunction with our guidelines that were released in ulcerative colitis, and that's to diminish immunogenicity and perhaps boost levels to induce more remission. This patient actually received 2 doses of ferrocarboxymaltose, and they were also supplemented in their vitamin D, of course, finally. And then they come back post-treatment, and we see that their hemoglobin's actually increased about 12.1. Their iron indices have actually improved. You can see this. It's a little early, but you can see this, that you start to see inflammatory markers and other things normalize. Their calprotectin is very telling here, right? It starts to normalize. This patient is having a remarkable response to the treatment, and hopefully she's out here on the road to recovery. She notes that, unsurprisingly, that her abdominal pain stopped after she stopped the oral iron therapy. So she listened to Dr. Long, stopped that. She continued her azathioprine, achieved remission, and 4 months later, her CRP, calprotectin, everything normalized, and her hemoglobin peaked to 14. She hasn't felt this great in ages. After 6 months of therapy, they did some proactive TDM here, and her IFX level was 11. She had no antibodies, and in this case, they just chose to discontinue the azathioprine and maintain her on infliximab monotherapy. They had a scope 6 months after biologic induction, and she had complete remission and healing. So you've actually impacted her iron deficiency, you've actually impacted her IBD. And I want to say one thing here is, we often talk about steroids as our bridge for biologic induction and remission. I want you to think about iron as another way, right? People have this anemia, it has profound quality of life effects, and in IBD, we showed that it has other associated morbidity, mortality effects, even in the postoperative state. So treating the iron deficiency anemia is incredibly important, and you can think of it as a bridge to help them at least feel better and function as a human, right, while you wait for your advanced therapy to take effect.
Neil, the only other thing I would add is when you're doing your post labs, I don't know that this is absolutely necessary, but the biggest thing to be aware of is low phosphate levels, right? That can be a complication. And so I typically will just add a phosphate level to my post labs, just have it as part of my standard after the iron repletion, just to have it documented. But, about 2% of people will develop hypophosphatemia, and obviously we don't want that. That can have detrimental effects, so.
And it can take a while to resolve, so it's not going to resolve immediately, but sodium phosphate repletion is what the treatment is. Most people that have it don't really have symptoms. We've determined that based upon our assessment. We do the same thing, but it's an important thing. If they come in with symptoms that are active, that you think this could be due to low phosphate, then assess that and treat it. It's relatively low, though.
So it's low, it doesn't stop you from prescribing.
No,
You counsel the
absolutely not.
patient, and you look for it when you need to.
Exactly.
Okay, that's good. That's one of our...
And I think that one of the best things about some of the novel iron therapies is just that you can give them in 1 or 2 doses. Over the pandemic, when patients were so fearful to come in, this has been a really wonderful thing to be able to replete kind of in a 1 or 2 stop setting.
Yeah.
Agreed.
All right, so remember those questions at the beginning. We're going to go through them now, and then we're going to get to Q&A here as well. So we looked at these iron indices, and when the question was, what would the following lab values likely tell us about the etiology? So this is a hemoglobin of 9, so they're anemic. Their TSAT is not too bad. Ferritin's a little high. It's higher than 100, which is permissible. Remember, ferritin less than 30 for traditional iron deficiency, but in inflammatory states like IBD, you can tolerate ferritin up to 100 to qualify. So in this case, is it poor iron stores in the liver? Is it adequate iron stores complicated by inflammation and poor gut absorption, or a functional iron deficiency? Is it excess iron release from the dysfunctional GI tract? Or is it excess ferritin production from the GI tract, which doesn't make any sense? So the answer is B. There's adequate stores, but we have a functional iron deficiency here. So next question. Which of the following statements describes the key distinction between absolute and functional iron deficiency? This is really a question that helps us, that we can understand by recalling the hepcidin role in iron homeostasis. So only absolute iron deficiency has a demonstrable impact on clinical outcomes. No, that is not true. Both absolute and functional iron deficiency, just iron deficiency, has an impact on clinical outcomes, morbidity and mortality. Both absolute and functional iron deficiency result in reduced iron storage pools. No. The reason it's called functional iron deficiency is because often the iron pools are normal. We just can't absorb iron and release iron from our stores. So absolute iron deficiency has reduced iron storage pools, but functional has normal. C, functional iron deficiency is characterized by a normal or increased storage pool, but diminished iron export and systemic utilization. That's right. That's exactly what we were just explaining. And D, absolute iron deficiency is commonly associated with hepcidin elevations. And functional is not. No. Functional deficiency systemic inflammation, hepcidin is up. All right, next question. In a hyperinflammatory condition like IBD, hepcidin levels are often elevated. How and why does hepcidin impact iron supplementation strategies? A, oral iron should be used at higher doses to overcome reduced intestinal absorption. What do you guys think about that?
No.
Judges say no. Oral iron should be used preferentially due to patient tolerability. What do you guys think about that? No. Intravenous iron should be used preferentially as it circumvents reduced intestinal absorption and overcomes the restricted ferroportin transport. Sounds like a yes to me,
Yes.
right? Inflammation can cause iron toxicity easily, thus iron must be used conservatively. No. All right, we've got 2 more good questions, and then I want to leave time for Q&A. To achieve iron repletion efficiently and conveniently for the patient, it is desirable to strive for repletion or near repletion in 1 to 2 doses of IV iron. Per currently approved product labeling, which of the following IV iron products can be administered in 1 to 2 infusions? Is it iron sucrose? The answer is no. You usually need many. You can give 200 to 300 milligrams in a dose. Ferric diderosamaltose and ferric carboxymaltose both can be given in 1 to 2 infusions. So the correct answer is D, both B and C. All right, so one more case. Let me open it up for Q&A. I'm going to have my colleagues answer here. KG is a 27-year-old female diagnosed with UC 4 years ago. She reports feeling tired and fatigued for the last 2 months. She wanted to wait and see if her symptoms improved over time due to her busy schedule. Her UC symptoms have flared. Labs show a serum ferritin of 28, hemoglobin 9.2, and a T-sat of 19%. Given the symptomatic IDA she's experiencing, her doc provides her oral iron. She sees you 2 weeks later with abdominal pain, nausea, and diarrhea, minimal rectal bleeding, and she admits she's unable to take the medicine twice a day because she thinks it's causing nausea. Which of the following recommendations is most appropriate? What do you guys think here? Should we start an IV iron product? Should we reduce the oral iron, switch to a different oral iron, or start IV sodium ferric gluconate?
I would do A. The ferric gluconate just requires many infusions.
I agree.
Absolutely right. So when they're intolerant to oral iron or it's ineffective or the anemia and the clinical context demand it, we're switching to an IV iron product here. All right, I want to actually get to some of the questions here. I'm going to go through them. We actually hit a lot of these during the course of our discussion. I'm going to ask them and see what our colleagues think. We talked about how to calculate iron deficiency. We talked about the Ganzoni's formula, but again, that's an estimate tool. You have to recheck every 4 weeks, proactively reassess, and then infuse iron until you hit your target. One question here that I like to answer is, would mesalamine toxicity, mesalamine-induced colitis, worsen the endoscopic appearance of her UC?
So that's a good question. Remember that in a small percentage, Gary will know the exact percentage, I'm going to guess around 3%, patients will actually have almost a paradoxical response to mesalamine where they can get increased diarrhea. And please do recognize this because you really do need to stop the mesalamine. I'm not sure I've actually scoped them during this. I've just recognized the phenomenon. What happens is as soon as they stop it, it actually gets a little bit better. So it's more of that dose response.
I agree. It's relatively low numbers. It varies with the agent and the study and the medication. But occasionally I have scoped them and actually have seen colitis itself that completely resolves with cessation of the mesalamine. This is years ago when that's all we had. Mm-hmm. But these days, just stop it. If the diarrhea gets worse, it's high-volume, watery diarrhea very commonly.
I agree with that. It's usually quite obvious, and you rarely end up re-challenging these patients, but once it's there, you have to document as an allergy. Mm-hmm. This is a good question. Do you hold IV iron in the setting of an active infection? They gave examples specifically like C. diff, but would you hold IV iron in an infection?
Right, so there's this theoretical risk, but in my practice, I have not seen that transpire. If the patient is very anemic and they need IV iron, I do give it. But in theory, it's never exactly at the right time. But in theory, IV iron could promote, particularly for C. diff and some other viral etiologies. But it's more of an association, isn't it, Gary?
It's an association, and it's typically with sepsis that it's been perceived. So C. diff not being really, quote, a bacteremia-type infection, I absolutely would give it in that scenario. But in other scenarios where a patient is septic, that's where I might hedge and say, do we truly need to do this at this point in time?
Right. They've got other bigger fish to fry at that point.
100%. Now, there's another question. It's pretty practical. Any way to fight insurance preference? Does it matter to fight insurance, and
Right.
under what reasons would you?
So I don't, actually. During the pandemic, I was actually quite successful with fighting some of the more frequent iron infusions, saying this patient only wants to come in once, and they're on immunosuppression. And so I was able to fight during that time period. But typically now, there's a step-through process, and I follow it. Certainly, if a patient, you do a test dose to iron Dextran and they react, then obviously you'll be able to move on to another product. But from my perspective, as long as you're doing the monitoring and you explain to the patient, the intricacies of the agent, I'm comfortable with any of them. Gary, you?
I do the same, in general. One thing to point out as well, ferromoxetol can look like hemochromatosis. So if you're interested in that and you see the isodensity of the spleen and the liver, and you're thinking this patient may have it, that's where you'd want to avoid that scenario and say you want another formulation.
Oh, and actually this is a really good point, though. If you have a patient who's active and you are trying to reassess their disease activity and you want to get an MR, you can't do an MR enterography within 3 months of giving IV iron. Right. So you do definitively want to do their assessment with their MR first and then give them the IV iron. So just make sure that that's a point that you make, because you kind of shot yourself in the foot once you've given them IV iron if you want to do an MR.
I see a question from the audience. We have a mic there if you'd like, or if someone could bring that to her. Or you can speak really loudly.
So mostly, you are correct, that it's one particular formulation. But our radiologists have now started saying, they really want us to not do IV iron. And typically it's that order. I mean, they're active, it's all at the same time. So I just really try to get the MR ahead of time. But you are correct.
One can do a CTE if you need at that time. That shouldn't be an issue.
Right.
I see another question over there. Oh, great. Oh. Okay.
Yeah, absolutely. CT is absolutely fine. That's what I do in that scenario.
Very good. If there are other questions, please, there's a mic there, or raise your hand and speak loudly. We'd be happy to answer questions. One last question, actually related to vitamin D. It was asked, what are your guys' personal vitamin D supplementation strategies?
I usually start with a little bit lower than Gary, but his way is absolutely fine. I do 50,000 once weekly for 12 weeks, reassess, and then I can titrate up or down. But the biggest important thing is once you've kind of repleted them with the high dose, regular pill bottles recommend a dose of like 800, a replacement. That is too low. You need 2,000 maintenance for any IBD patient in terms of a daily replacement dose.
I agree. That's what I do too.
And I'll do the same, but occasionally I'll give 5,000 once a week as well to some patients that truly have reasonably high levels just to maintain them, because remembering to take it every day is sometimes difficult.
Last question here. Can you give IV iron at the same time as a biologic infusion?
Yes.
Yeah.
I just don't do it the very first time to make sure they don't react to the iron, but then after that I do it with their biologic.
Yeah, and that's just good management practice, right? Because if they have a side effect, you're not sure which medicine it was to. So.
I would say at the same sitting, but not simultaneously, not in both.
Oh, right. They're not getting an IV going in at the same, but they come once, they get their biologic, and then they get their iron.
Yeah,
no, yes.
Absolutely.
Yeah, just to
good
clarify.
Clarification.
Yeah.
Are there any closing remarks from our panel?
No, thank you so much for your attendance. This has been wonderful, and thank you for attending the meeting. We have a great session coming up next on extraintestinal manifestations, so I hope to see you all there. Thanks for joining.
Thank you very much.